All right, today we're going to be talking about prenatal development, pregnancy, and birth, so the very beginning of child development. And we'll start with the genetics of fertilization and some important terms. So we've got cells. Here are two different pictures. Each cell has a nucleus, and inside the nucleus are the chromosomes. Those are located in the nucleus of every cell. Which contains the chromosomes contain the genes and the DNA that carries the genetic information. So here are those chromosomes that come in pairs. You can see them here. Here are DNA. So the DNA is the material that makes up your genes, which bears the hereditary characteristics. And a gene is a segment of DNA that contains a chemical blueprint for manufacturing a particular protein. So a gene is a little specific part of the DNA. Same with here. So we've got our cell with our nucleus that houses the chromosomes that are made up of this, have all the DNA, and genes are specific segments of DNA that contain blueprints for manufacturing proteins. Here's a map of human chromosomes. Humans have 46 chromosomes. They have 23 pairs. So you can see each chromosome, there's a pair. And you get one chromosome from mom, one chromosome from dad, making that pair. 23 pairs, and you can see the 23rd pair determines the sex of the baby. If it's XX, two X chromosomes, you've got a girl, X and a Y for a boy. So prenatal development is broken into stages. We have the germinal stage, and this is when the developing baby, would call it a zygote in this germinal stage. This is the first 14 days, so very early on from fertilization to implantation. Then we move to the embryonic stage. This is week 3 to 8, and then the fetal stage from week 9 to birth. So we're going to watch a little video about just the beginning of development from fertilization to the formation of the neural tube.
In this video, then, we'll look at the beginning of development, looking into the ovary at an unfertilized egg. It then gets fertilized by sperm, which travel down the fallopian tube. So here, millions of sperm coming along. Several of them will hit the egg and try to penetrate it, but one will win, as it were, go into the nucleus. And then there's a reprogramming process where the male and female nuclei have their genes set aside to be turned on and off for early development. Here you see early cleavage stages occurring, and this is one of the early growth phases. As the embryo moves down the fallopian tube, it's going to form an important stage called the blastocyst here in a few seconds. Of course, in real life that takes days, about 5 days. At this stage, then, I'd like to draw your attention to.
You can see the blastocyst as a ball of cells. So the cells are dividing, and by the time we have this blastocyst stage, we've got a ball of cells.
The inside of the blastocyst, where there are cells called the inner cell mass, which I'll be abbreviating as ICM. Those are the cells that make the entire animal. And the outer cells give rise to the placenta and other supporting tissues. At this stage, the embryo implants into the wall of the uterus. This is when a pregnancy is really initiated. And now we'll see those blue inner cell mass cells form a disc, and then as the cells continue to grow, they change their physical positions, their kind of geographical relationship to one another. And you'll see that represented here as this disc gets transformed into an embryo. Those lines represent sites where cells are migrating in and out. And here's an important stage when the 3 beginning layers of the embryo, the so-called germ layers, are formed, and I'll come back to that in a few minutes. As development proceeds, there's more growth and movement of cells. It'll begin to form a neural tube. Here it turns, and appendages start to bud out. You see the head forming and the eye. and then eventually we get a small embryo, and some months later, of course, this would be born as a young baby.
All right, so during this embryonic stage, you can see in the very beginning, right, we get the cell division, the blastocyst, or this ball of cells that then flattens out and elongates and folds in kind of over itself and becomes what we call the neural tube. The embryonic stage, weeks 3 to 8, this is a really fast-paced stage where all major organs are constructed. In the third week, circulatory system is formed and the heart starts to beat. Between 20 and 24 days, the neural tube is forming, and this will differentiate into the brain and the spinal cord. By day 26, you start to see the beginning of arm buds. Day 37 of pregnancy, leg buds begin to appear. By week 8, the embryo is 1.5 inches long, and internal organs are in place, and the embryo begins to look human. There are some basic principles of prenatal development to keep in mind. One of the principles we call proximodistal. This means that prenatal development grows or happens from the middle to the outside. So things in the middle, the brain, the spinal cord, the internal organs develop first, then to the outside, like arms and fingers and toes, later. Cephalocaudal, that's growth from the head. Cephalo means head or top, to caudal meaning feet or bottom. So you see that development happens first in the head and then towards the feet. And then mass to specific sequence. This means that large structures appear before the finer details. And we also see this in development. In terms of movement, we see large movements, or what we call gross motor movements, children are able to do before finer movements. And so you can kind of see the idea of proximodistal, right? First, things start to develop towards the middle as opposed to the outside, like we said, fingers or toes. And then cephalocaudal, here we are at week 4. We've got a lot happening in the head, less happening down here in terms of development. And then here's week 9, again, still a pretty large head. In terms of cephalocaudal development, more detail is now happening towards the outer parts of the embryo, and that will continue in terms of development as the pregnancy continues. In the terms of the fetal stage, week 9 to birth, this is where the baby grows dramatically, the body structures are refined, and the building blocks of the brain are fully assembled. And neurons start to ascend to the top of the neural tube. They reach their final, what we call staging area, and then they start to differentiate, meaning they start to turn into and move towards the part of the brain that they will eventually be housed in and begin to act the way that we need them to act in that particular part of the brain. The brain grows dramatically month by month during the fetal period. You can see here 4 months, 7 months, and then by 9 months, you've got a brain that looks very much like a typical brain with all of those folds and creases and things like that. In terms of the age of viability, that is the first possible time in which the baby may be able to survive if it was born, and the age of viability is about 22 weeks. It's the earliest date for possible survival. We need to be sure that the baby's lungs are mature enough to breathe in oxygen and expel carbon dioxide. By the 25th week of pregnancy, viability is above 50% if acute care is available, meaning this baby will need lots of care in the hospital, But if that's available, you've got about above a 50% chance of survival. Birth weight is important to the health of a baby, and babies gain a lot of weight towards the end of pregnancy. So these very early babies are very, very small, and the baby needs as much time in the womb as possible. As I said, during the last 2 months, the fetus gains almost 5 pounds. So there's a lot of weight gain during the last months of pregnancy. In terms of pregnancy, the gestation period is about 267 to 277 days. This is divided into trimesters, about 3 months each, and each woman may vary in her experience, both physical and emotional, of pregnancy. There's a lot of physical changes that happen and a lot of emotional changes, and certainly for every person, these things vary quite dramatically. Here's a general idea of what to expect in the first, second, and third trimester, but again, every woman is different. So in the first trimester, following the implantation of the blastocyst, remember that ball of cells into the uterus, there's a lot of hormones, and those hormones might produce fainting, headaches, fatigue, tender breasts, and morning sickness, that feeling of nausea. In the first trimester, miscarriages are the more prevalent, and this is a spontaneous abortion basically from the body. Roughly 1 in 10 pregnancies end in a miscarriage. It's a really high number that a lot of people are not aware of. Miscarriage rate increases to 1 in 5 for women in their late 30s. So miscarriages rate increases as mom's age increases. But this can be a time of not feeling great. I can tell you from my own personal experience, lots of morning sickness, lots of fatigue. It can definitely be a time where mom doesn't feel so good. The second trimester, typically people start to feel much better. By week 14, the uterus grows and the mom will need maternity clothes. This is, again, typical, but not always. There are people who continue to have morning sickness into the second and even third trimester. I happen to be one of those people. Again, at this point, finally, you start to see, can tell that you're pregnant. All of a sudden, you can sort of see a little bump, and you start to, up until then, it's very maybe almost theoretical that you're pregnant. But here you start to see changes in your body, as well as quickening occurs. These are the first indications of movement of the fetus. So mom might be able to feel the baby moving around for the first time. And during this time, this is when feelings of attachment might begin. So because your body is changing, start to feel the baby, it starts to feel perhaps more real. And there's a strong sense of bonding that can occur at this time. And not always, again, not for every person, but this can be a time when we start to see that. And a strong sense of attachment during pregnancy predicts positive bonding after birth. Again, for most people, not for everyone. And some people who moms go through pregnancy and don't feel very bonded to their child, doesn't mean that won't happen later on. But this is kind of a trend that you typically see. And in the third trimester, the physical symptoms and emotional states, this is when the baby is growing, the mother's body is growing quite a bit, and so you may have leg cramps, backaches, numbness in the lower limbs, heartburn, insomnia, really having a hard time sleeping at night. Can be a very uncomfortable period of time. Mom may experience uterine contractions as the baby sinks into the birth canal, and then some anxiety because now you're starting to focus on the birth and what that's going to mean. So definitely some emotions for sure. Pregnancy is not a solo act. Dads also may experience strong emotions. I almost want to take that may out. Dads experience strong emotions. They may feel concerned about this life change. They're worried about the whole process. They see perhaps mom not being very comfortable, maybe are worried for the health of the mom, for the health of the baby. Other things, some negative forces that may contribute to distress during pregnancy, economic concerns, right? There's a big cost to having a child in terms of everything. Can you still live in, do you have enough room in the place that you're living? Do you need to move to a larger place? Clothing, diapers, schooling, etc. So economic concerns may add to stress during pregnancy, possible lack of access to prenatal care, proper foods, social support. If you don't have social support during pregnancy, that can be very difficult. So these are all things that can lead to stress during pregnancy. In terms of positive forces, the presence of a loving partner may predict a more happy pregnancy, but just a perception of being cared about and love, a sense of connectedness, really to anybody in terms of that social support is extremely helpful during pregnancy. All right, what are some during pregnancy things to consider and that cause some maybe stress or worry? The idea of birth defects. These are health problems at birth, and they can be caused from exposure to teratogens during prenatal development or from chromosomal or genetic abnormalities. A teratogen is the name for any substance that crosses the placenta and harms the developing fetus. So anything like alcohol, drugs, things like that that can cross the placenta and harm the fetus. Teratogens exert their damage during what we call a sensitive period. So some facts about teratogens: they cause the most damage during the embryonic stage of prenatal development. They can cause brain damage throughout the entire pregnancy, so you want to be careful because really the brain is developing through the entire pregnancy. There's often a threshold level above which damage occurs, so a small exposure to some substance may not be damaging. However, once you reach a certain level, the damage to the developing embryo may occur. And they're completely unpredictable, which means we don't know what that threshold is. And that's part of the difficulty, is you don't know what that threshold is that may lead to exposure to some substance, may lead to problems in development. So some examples of known teratogens of infectious diseases. So if mom gets sick during pregnancy, rubella, AIDS, herpes, etc., those sorts of diseases can lead to negatively impact the development of the baby. Medications. Certain medications that are perfectly fine to take when you're not pregnant can negatively affect the developing baby. So certain antibiotics, certain antidepressants, anti-seizure drugs, even something like Advil, they recommend you don't take during pregnancy, which is something that oftentimes people take quite a bit of and don't think about when you have a headache or something like that. So medications, you need to be very cautious of what medications you take during pregnancy. Recreational drugs, cocaine, methamphetamine, other environmental toxins like radiation, lead, mercury, etc., and vitamin deficiencies. These are all things that can threaten the development of the baby, and these we call teratogens, threats from the outside, meaning something that's coming in from outside the mom and outside the body. In terms of risk analysis in pregnancy, it may seem like so many things can harm a baby, but of course driving a car is dangerous, and we do that too. 60 years ago, it was assumed that the placenta screened out all harmful substances, and so if the baby had a birth defect, it was unavoidable. However, we now know that that thinking is not correct, and there were two big events that changed that thinking. One is that an Australian army base had an increase in babies born blind, and found it was correlated with an epidemic of German measles 7 months earlier. So there was this correlation between sickness and babies born blind. And then there was a rise in British newborns with deformed limbs, and that was traced to thalidomide, which was a drug that was used for nausea and was widely prescribed in the 1950s. So again, the understanding that taking some kind of medication may impact the development of the baby, and that the placenta wasn't able to screen out everything that was potentially harmful. I'm going to talk about two common teratogens, nicotine and alcohol. However, know that research is really hard to do on this topic because it's hard to know exactly what amount of exposure mom and or the baby had that would cause harm to the developing baby. How can we do this type of research? Thinking back to research in development, we certainly can't do an experiment. We certainly can't recruit a bunch of pregnant mothers and randomly assign them to one group who would drink alcohol and one group who wouldn't drink alcohol and look for the effects, right? Or one group who would smoke cigarettes and one group who wouldn't. We can only do correlational research, which means we have to do research where we just ask people, how much alcohol did you drink? And then we would look at the baby once the baby's born and do kind of different types of assessments, physical assessments, cognitive assessments, and things like that. Or we'd ask the mom, how many cigarettes did you smoke? And then again, look at the effect on the baby. So all we can do is ask those questions. And of course, self-report questionnaires might be unreliable. Moms are pretty unlikely to tell you exactly how much alcohol they're drinking or how many cigarettes they're smoking because particularly in questionnaires, there's a tendency for people to try to present themselves in a positive light. And so they may underestimate in their questionnaire how much alcohol or they're using or cigarettes they're smoking. So it's really hard to really understand this relationship between teratogens and the outcome. But what we do know is that in terms of alcohol, excessive consumption contributes to a chance of fetal alcohol syndrome, which is a specific syndrome. It affects the developing baby. There are specific facial features, cognitive problems, emotional problems, etc., that we see in moms who drink a lot of alcohol while they're pregnant. U.S. public health organizations recommend no alcohol during pregnancy because we even see that milder kind of issues in children of mothers who drink a little bit of alcohol. So it doesn't have to be excessive alcohol. And we call those fetal alcohol spectrum disorders, which may not be the entire fetal alcohol syndrome, but there are problems that tend to occur with infants whose moms drink alcohol during pregnancy, things like learning disabilities, etc. So the recommendation is no alcohol during pregnancy. Nicotine constricts blood vessels, and good circulation is very important during the development, during prenatal development. And smoking leads to an increased risk of smaller than normal and less healthy newborns. And it's real interesting that continuous exposure to secondhand smoke can be as dangerous to the developing fetus as firsthand smoke. So the rule of thumb, don't drink, smoke, take drugs, and avoid exposure to teratogens during pregnancy. That's really the best rule. Certainly we know there are people who have drank some alcohol during pregnancy and end up with healthy babies, but the problem is that we really don't know how these substances work in terms of development. We don't know how much and at what time during the pregnancy it's okay to perhaps have a sip of alcohol. And so because we don't know, the rule of thumb is don't do it. The 4 principles of teratogens are most likely to cause structural damage during the embryonic stage. As I said, they can affect the developing brain throughout pregnancy, and that is really a key. I'm going to come over here, that you can see that the central nervous system, which is the brain and spinal cord, start to develop right here at week 2 and continue developing all the way through the birth of the baby. And so, because the structures of the central nervous system are developing basically through the entire pregnancy, they can be affected or negatively affected by substances during the entire pregnancy. So you want to be really careful about any type of teratogen exposure, because it has a possibility to affect in a negative way the brain and spinal cord. Teratogens appear to operate in a dose-response fashion. Like I said, the threshold level, that there are certain levels when you get to a certain high enough level, you see this negative impact. But the damage is unpredictable. It really depends on the particular fetus and the particular mom, and so we really don't have a good way to predict when or it may be okay to have certain exposures and when it's not. And teratogens may also exert their influence long after exposure. So you might see learning disabilities as the child is much older. You may not see them right at birth. This chart talks about the critical periods, and we say that teratogens have their most potential for damage during the time when a particular structure is forming. And so you can see here, we talked about the central nervous system, the brain and spinal cord basically forms through the whole pregnancy, meaning there's a risk to development if mom is or the baby is exposed to any of these teratogens pretty much through the entire pregnancy. In fact, these structures, that neural tube starts to develop around 2 weeks. This is before many people even know they're pregnant. And so if there's a possibility you might be pregnant, try to stay away from any of these possible teratogens. You can see heart, right, developing at about 2.5 weeks, all the way up to 8 weeks. So this is the time when exposure to a teratogen is more likely to lead to heart defects, right? You can see eyes here, the palate, etc. So the critical period is basically when is the embryo at the highest risk of major abnormalities if they're exposed to some sort of teratogen. And you can, okay. This was just an interesting quote to think about. It says, I was 9 years old when my mother announced she was pregnant. I was the one who was most excited. My mother was a heavy smoker, Colt 45 beer drinker, and a strong caffeine coffee drinker. One day my mother was sitting at the dining room table smoking cigarettes, one after the other. I asked, isn't smoking bad for the baby? She made a face and said, yep, so what? I said, so why are you doing it? She said, I don't know. During this time I was in 5th grade and we had seen a movie about birth defects. My biggest fear was that my mother was going to give birth to a fetal alcohol syndrome infant. My baby brother was born right on schedule. The doctors claimed he was a healthy newborn. Once I heard healthy, I thought everything was going to be fine. I was wrong. My baby brother never showed any interest in toys. He just cannot get the right words out of his mouth. He has no common sense. Why hurt those who cannot defend themselves? And so that's the idea that, there can be these effects that maybe you don't see right at birth, but that they appear later on. The one thing about a lot of these teratogens is that these are completely avoidable, right? There doesn't need to be any fetal alcohol syndrome if mom doesn't drink any alcohol during pregnancy. No effects of nicotine if mom doesn't smoke any cigarettes, right? There are plenty of things we can't control during prenatal development, but there are many things we can. So again, being cautious is the best advice. And in terms of what we can't really have much control over. Threats from within, these are chromosomal and genetic disorders. We talked about chromosomes, that each a human has 46 chromosomes in 23 pairs. An embryo may miscarry if the developing baby is missing a chromosome or has an extra chromosome. That does happen. There are some chromosomal abnormalities. For instance, Down syndrome, which is also called trisomy 21. And this occurs because there is an extra chromosome that is adhered to the pair of chromosomes, pair 21, why it's called trisomy 21. So instead of having two chromosomes, these individuals have 3. Why does this happen? Well, it seems to be related to maternal age as well as paternal age. So in terms of maternal age, as mom gets older, the risk for having a baby with Down syndrome increases. We used to think it was just maternal age, but now there's research to show that it's also dad's age as well. As dads get older, the risk increases. The symptoms for Down syndrome are distinctive physical features, a more flat facial profile, an upward slant to the eyes, more of a stocky appearance, an enlarged tongue. They're at risk for heart defects and childhood leukemia, mild to moderate intellectual impairment, a shortened lifespan with the average life expectancy of 58 years old. So, in terms of these chromosomal and genetic abnormalities, genetic disorders or single gene disorders, this is when there's a specific gene that we can find that leads to a specific abnormality. Okay, so genes come in pairs. There's one on each chromosome, one inherited from mom and one inherited from dad, and they determine specific traits. Most traits are dependent on many genes, right? It's not a single gene that leads to, I don't know, your sense of humor or your level of intelligence or something like that. But single gene disorders occur due to a flaw in a particular gene. And we're going to talk about some modes of inheritance of genetic disorders. So there can be what's called an autosomal dominant inheritance pattern, or dominant genes. And you might remember this from high school biology or college biology class, some basic genetics. So when there's a dominant gene, a person who inherits one copy of the gene always gets the disease. All right, so we can go here and look at the autosomal dominance inheritance pattern. And dad has the condition, whatever it is. This check mark, he has one working gene and he's got one non-working gene. Mom doesn't have the condition, so she has 2 of the working genes. And then if you think about the possible combinations, right, this potential child could get the working gene from dad and this working gene from mom and not have the condition. This child could get the working gene from dad and this working gene from mom, again, and not have the condition. This child could get the non-working gene from dad and this working gene from mom, but because it is dominant, right, all you need is one of the non-working genes, so this child will have the condition. And this child also could get the non-working gene from dad, this other working gene from mom, but because it is a dominant inheritance pattern, this child will also have the condition. So if one parent has the genetic disease, each child has a 50-50 chance of inheriting the disease. An example of this is Huntington's disease. Huntington's disease has an autosomal dominance inheritance pattern. So if you have one of the genes for Huntington's disease, the person will get the disorder. And this is a progressive breakdown of neurons in the brain that leads to really significant cognitive, motor, and psychiatric effects. And death occurs about 10 to 30 years after the symptoms emerge. We don't have any treatment for Huntington's disease. And so that's one example of a autosomal dominant pattern. Now, there's also autosomal recessive inheritance. A recessive gene the child gets the illness by inheriting 2 copies of the abnormal gene that causes the disorder. So the odds of a baby born to people who carry the gene are 1 in 4. So in this case, with autosomal recessive, the mom and dad are both carriers, meaning they have 1 abnormal gene, but they have 1 working gene, and so they don't have the disorder. If for a recessive disorder, you need 2 of the non-working genes. Okay, so mom and dad probably don't even know they have this disorder. A lot of my research is on a disorder called cystinosis, which we will look at and talk about in a few minutes. But cystinosis is an autosomal recessive disease, which means mom and dad are both carriers for this cystinosis gene, but they don't know it because they have 1 working gene. And then when they get pregnant, these are the possible combinations, right? The child could get 2 normal genes, 1 from mom, 1 from dad, and not even be a carrier of the abnormality. This child could get the working gene from mom, the non-working gene from dad, be a carrier and not even know it. This child could get the working gene from mom, the non-working gene from dad, or I could do the opposite, sorry. Non-working gene from mom, working gene from dad, be a carrier. Or the child could get both of these non-working genes, have 2 copies of this recessive gene, and be affected with the disorder. So examples of autosomal recessive is cystic fibrosis, sickle cell anemia, Tay-Sachs, and like I said, cystinosis, which is one of the disorders that I have worked on. Let's see if I can play this video for you. This is from the Cystinosis Foundation. As I said, cystinosis is a genetic metabolic disorder in which cysteine accumulates, the amino acid cysteine, and the body can't break it down. So it accumulates in different parts of the body, including the brain, the eyes, and we don't have a cure. We have found the gene that is responsible for cystinosis. It's a very rare disorder, and so actually the parents of this child, Natalie, her parents started a research foundation where they started to raise money for researchers to try to understand cystinosis. And so I'm going to let you play this video, or I'm going to play this video so you can hear her story.
Cystinosis is a rare disease that affects every cell in the body. It slowly and eventually destroys the kidneys, eyes, liver, muscle, and central nervous system. I have cystinosis. My parents were told that I would not live to graduate from high school, but the doctors were so wrong. It does not define me, it does not make me weak. Cystinosis has made me stronger. There are people in their 20s who have recently died from cystinosis. I am 25 years old, and I often think about how long I have to live. I am praying for a cure for all of us.
It's not the name of a disease. It's, you see faces, you see the patients, you see the parents, you see their fears and the hope. I always think about them, and this is why we want to do our best.
Brooke is full of energy. She's courageous, she's strong, and she just lights up a room. You know, you can't miss her.
I had a really tough time with the diagnosis. I got a 2-minute phone call from a doctor telling me, "I'm sorry, your daughter has an incurable disease." Literally within an hour of getting the call from the doctor, I picked up the phone and called the CRF. It just instantly made me feel like I wasn't alone.
A group of doctors came into the room, and literally our hearts dropped, Lauren and I, that we found out that our kid had cystinosis. We immediately went online and found out that it was a terminal disease. And at that point, we both went to tears.
I absolutely grieved this diagnosis. And I remember asking him a question. Is Landon going to be able to go to school? It's because I didn't know what cystinosis meant. I never heard of it before. Most parents say, I will do anything for my child. Give this to me, like, let me do this. I would feel better if it were me with cystinosis than my baby.
For children like Brooke and Landon, the management of their condition is really a 24-hour-a-day job. The parents have to become expert pharmacists. They have to be expert nurses. The children often get a gastrostomy tube, which is a tube that provides a direct access through the stomach wall into the stomach. And so the parents start giving medications through this piece of plastic that their child wasn't born with. So the parents have a tremendous learning curve where they're picking up all sorts of medical knowledge and nursing knowledge to look after their child as best they can.
Brooke takes about 20 doses of medication a day, and that's throughout the 24-hour period in a day. The poor kid hasn't had a full night's sleep ever in her entire life because I do have to wake her up to take her life-saving medication.
Everything takes a lot of energy. His body is just dragging along. And his teacher said that she notices that at some point during the day, it's almost as if he's willing his body to go.
With cystinosis, in spite of taking the medication well, many, if not all of these children and adults have muscle weakness, which can be slowed with the medication but may not be stopped. And so this progressive muscle weakness makes it harder and harder to do things which are just everyday activities like speaking clearly, even swallowing liquids.
My biggest fear now is that I might lose my eyesight. It is hard for me to take hourly eye drops, but when I think of children like Landon and Brooke and how hard it must be for them, I realize how much we need new treatments.
These cystine crystals begin to build up in the cornea, which is very bad because your cornea, not only is it a highly sensitive tissue, but it also it's the window to the rest of your eye. And so you really want to remove those crystals and allow that completely transparent window to let light in. So we are using a material called a thermoresponsive hydrogel. This material starts as a liquid at room temperature, and when you heat it up to body temperature, it turns into a solid. And we can use that to our advantage because it goes in like a liquid drop and it collects right in here. And the change in temperature causes it to turn to a solid depot. And it just rests there for the full course of drug administration. So in the case of cysteamine, for 1 week at a time, and then you actually manually remove it and put a new one in. And I'm liking what we're seeing. And with the grant funding from CRF, I think that that's only going to continue apace. And I think that within 2 years, that we will have it in some patients.
What we're really hoping for is the research that the Cystinosis Research Foundation is supporting in gene therapy, the research of Dr. Shirky, which hopefully soon will be able to take stem cells from the blood of these patients, correct the defect in the test tube, grow up the healthy stem cells, and then give them back to the patients, and hopefully cure the disease. That's the goal.
So how do you fix a gene in all tissues? I was lucky enough that the Cystinosis Research Foundation trusted me enough to give me money to start this bone marrow stem cell and gene therapy project for cystinosis. And now we are really close to go to clinical trial. It will be huge for cystinosis, but if it's a success, it will be also huge for many disorders. We are really very close every day. It's one more step forward, and I really have good hope that in 2017 we will have a clinical trial open.
If we really figure out how to do it right, to really cure cystinosis, we could rapidly turn this into cures for many other genetic diseases, blood diseases, certain cancers, diseases of growth, diseases of even potentially diabetes. So if we can bring this to the finish line, we can then show the way to maybe hundreds, maybe thousands of other genetic diseases. So this could be a real benefit to mankind.
My hope for Brooke is that she can one day, look back and we have to remind her about the disease she once had. That's my biggest hope.
I know with the help of the CRF that there's no doubt in my mind that there will be a cure for this disease for my son.
I was almost 12 years old when I made my wish to have my disease go away forever. With researchers like Dr. Shirky and others, I believe we will find a cure for cystinosis. I want to thank cystinosis for letting me see the beauty in life and for allowing me to see the beauty in every person who was affected by this disease. We always have each other to lean on, and we have hope that the cure will be found soon. I really believe that we are one step closer. Thank you for never giving up.
So this is just one of many genetic disorders. Again, this is autosomal recessive, meaning mom and dad didn't know they even carried the disorder, and then had a child that developed cystinosis. And so we're learning as much as possible about how to cure, if possible, some of these disorders. This is a goal in the future with what we're learning about genes and genetic engineering. Intervention, sorting out the options. Some people choose to go to a genetic counselor. These are counselors who talk to couples about their own or their children's risk of developing a genetic disorder. They give advice about available treatments, and the goal is to let couples make a good mutual decision. So if somebody knows they may be a carrier for some disorder, or they do have some genetic or chromosomal disorder themselves, a genetic counselor can talk to them about the risks, etc. There's also genetic testing, like a blood test that determines whether a person carries the gene for a specific genetic disorder. One of the examples of this is a genetic disorder called Tay-Sachs. That's a fatal genetic disorder that results in progressive destruction of the nervous system. There's the absence of a specific enzyme, and without this enzyme, a fatty substance starts to accumulate in cells, especially neurons in the brain, and this ongoing accumulation causes progressive damage to the cells. The disease process begins early during the fetus, in the fetus during pregnancy. A baby born with Tay-Sachs appears normal until about 6 months of age, but then its development starts to slow. And by 2 years of age, most children experience recurrent seizures and diminishing mental function. Basically, the cell isn't able to get rid of this substance, and the cells grow and grow. And you can imagine if the cells in your brain are growing because they can't get rid of this particular substance, the skull doesn't grow, right? So the brain is basically pushing against the skull, which causes seizures and brain damage. The infant gradually regresses, maybe starts to be unable to crawl, turn over. The child becomes blind, cognitively impaired, paralyzed, non-responsive. And death usually occurs by the age of 5 at Tay-Sachs. So while anyone can be a carrier of Tay-Sachs, the incidence of the disease is significantly higher among people of Eastern European Jewish descent. Approximately 1 in every 27 Jewish people carry the Tay-Sachs gene. So this would be a situation, this is actually my background, that you would want to perhaps to get a blood test to see if you are a carrier of this gene before you get pregnant. So carriers of Tay-Sachs are people who have one copy of the inactive gene and one copy of the active gene, and they're healthy, right? They have one working gene and one non-working gene. They don't have Tay-Sachs disease, but they could pass this gene on to their children. And a child who inherits one of the Tay-Sachs genes would be a carrier like the parent. But if both parents are carriers and their child has that 1 in 4 chance of having Tay-Sachs disease, okay? And so this is a case of, for me, it was the case where I went to get a blood test before I got pregnant to see if I was a carrier of this gene. And in fact, I was. And so my husband then went to get a blood test to see if he was a carrier of the gene, and he wasn't. So in order for an autosomal recessive disease to be an issue, both parents would need to be carriers, and then you would have a 25% chance of the baby having the disorder. But if only one parent is a carrier and one is not, then there's no risk. So that's the case, that's the situation where blood testing as well as potential genetic counseling would be important. So like I said, a simple blood test can identify Tay-Sachs carriers as well as carriers for other disorders like cystic fibrosis and a number of other things, cystinosis. And if both parents are carriers, they might want to consult with a genetic counselor for help in deciding whether to conceive or whether to have a fetus tested for, again, Tay-Sachs or any other of these genetic disorders. There's prenatal testing available that can be done, again, around the 11th week of pregnancy using this CVS procedure that involves removing a tiny piece of placenta. And this can be for not just Tay-Sachs, but other genetic diseases. The fetus could also be tested around the 16th week of pregnancy using an amniocentesis. And in this procedure, a needle is used to remove a sample of the fluid, that amniotic fluid that surrounds the baby. Okay. And there may be other options, again, based on the decision of the parents. They may want to use some kind of assisted reproductive therapy for carrier couples who don't want to risk giving birth to a child with Tay-Sachs, using in vitro fertilization, etc. So there are lots of things to think about. We certainly are learning more and more. This is, again, one example. Cystinosis is another example. And so we have many different prenatal tests that are available now that weren't available, 50 years ago, maybe not even 30 years ago. Ultrasound is now very common, used to date the pregnancy, when they think the pregnancy started, chart the fetus's growth, can also reveal structural abnormalities. There are 3D ultrasounds. Here's a picture of a 3D ultrasound. You can actually see the baby's face, and there are 4D ultrasounds where you see this baby moving around. It's pretty amazing. We talked about the CVS procedure during the first trimester. You remove a piece of the developing placenta through the cervix or through the abdominal wall. And the placenta provides oxygen and nutrients to the baby and removes waste products from the baby's blood. And so basically getting a little bit of the placenta, you can get the baby's genetic makeup. This test is usually done between 10 and 13 weeks of pregnancy, which is earlier than other prenatal diagnostic tests like amniocentesis. That's a more common, kind of a older, more established test, and can reveal certain conditions like Down syndrome. There are risks involved. There is a risk of miscarriage by disturbing that placenta, 0.5 to 1% risk, and also a chance of limb impairment. So to make the decision to have this test, you have to be aware of the risk involved and also must be prepared for the results, right? If they find out that there is some sort of genetic chromosomal abnormality, you have to be able to take those results and think about what you would do in those situations. Amniocentesis, that's another prenatal test in the second trimester, typically around week 14, and this is where you remove cells from the amniotic fluid and test for genetic or chromosomal conditions. This has a risk of miscarriage about 0.25 to 0.5%. All right, the newborn. Let's say we finally have the baby. We've gone through all this prenatal development. The first test the baby ever gets, here you are in college, you've taken so many tests, but the first test you ever got was something called the APGAR test or the APGAR scale. It's immediately after birth, and the baby is rated from 0 to 2 for each category. Here they are, at 1 minute after birth and 5 minutes after birth. And so they rate on appearance, right? Is the baby blue? That's a score of 0. Blue only at the extremities is a score of 1, and no blue at all, that's a score of 2. They rate the pulse. Again, you can take a look here. If they grimace in response to some kind of stimulation, like a little pinch, no response, would be a 0. A feeble cry, a 1. Sneezing, coughing, pulling away, that's a 2. Activity, is there no movement, some movement, or active movement? And respiration, is there breathing, weak or irregular breathing, or a strong cry? And they're rated on this APGAR scale at 1 minute after birth, and then again at 5 minutes after birth. Over 7, that's a healthy baby. Under 7, the baby must be monitored, might need to be resuscitated, and may need to go to the NICU, that's the neonatal intensive care unit. So there are variations in birth weight that can be related to overall physical and cognitive outcomes for the baby. A very low birth weight baby, a low birth weight baby, that's a body weight at birth of less than 5.5 pounds, or a very low birth weight baby, that's a body weight at birth of less than 3.25 pounds. So these are very often preterm babies. And birth weight is important because we see that with low birth weight, there tends to be lagging physical and cognitive development. Not always, but those two tend to be associated.